introduce Maureen Kelly and Suzanne Kuyawa.
Good morning. On behalf of Susie and myself, I welcome you this morning to our talk on collaborative care, management of the pediatric patient with IBD. I also thank you for coming out so early in the morning. For those of you coming from the East Coast, it's not so bad. For some of you coming from the West Coast, it's a little tougher. I also want to talk a little bit about how far the care of patients with IBD has come. I've been a nurse practitioner for the past 17 years, and I've seen it come a very long way, and I'll talk about some of that as I give my talk this morning. I also think it highlights how far nurse practitioners have come in 17 years. When I first started in pediatric GI, I have a few former students in the audience, and they probably heard this story before, but when I first started in pediatric GI at UNC, we only had nurse practitioners in the NICU, none in any of the specialty areas. And so they didn't really know what to do with me when I started. And I was given a 5-hour, 1-day-a-week clinic to care for constipated patients. And following that, it got a little boring, and so then they started letting me have patients with reflux in my clinic. And then we started to see abdominal pain patients, and it went on and on from there. And so probably for about the past 12 years, I've been putting a lot of work into patients with inflammatory bowel disease. This is my disclosure. I'm not going to go through the learning objectives. We just are going to be talking about diagnosis and medical and surgical management, as well as psychosocial concerns this morning. So what are inflammatory bowel diseases? When we think about inflammatory bowel diseases, we think about Crohn's disease and ulcerative colitis. And those are the two main inflammatory bowel diseases. When we think about other diseases that fall under that category, there is also what we call indeterminate colitis. So about 10 to 15% of the time, we don't know whether the patient has Crohn's disease or ulcerative colitis because they have features of both. And so they're called IC or IBDU. And eventually, about half the time, we figure out that it is one or the other. But there are distinct features of each, and usually we have a diagnosis made pretty early on in the disease process. What symptoms do we see? You can see here from this slide, and this slide is culled from several sources. You can see that they all have similar symptoms, but you see more bloody diarrhea in patients with ulcerative colitis. You see more abdominal pain in patients with Crohn's disease. You see more weight loss and resultant growth failure in patients that have Crohn's disease. And then fatigue is a problem that we see less often, but more prevalent in patients with Crohn's disease. As far as what you see in the GI tract, it's important to note if you have a patient who has, for example, perianal disease, then their diagnosis is going to become Crohn's, because Crohn's disease affects the entire GI tract from the mouth to the anus. Most often, it is distal ileal disease or ileocolonic disease. We may see perianal involvement in the form of skin tags, in the form of fistula, but usually the rectum is not involved. Key to Crohn's disease is that they have skip lesions, so they have alternating diseased intestine with healthy intestine. We see inflammation through all the layers of the intestine. Fistula, strictures, and abscesses are common, and then constitutional symptoms are more common in Crohn's disease than in ulcerative colitis. In other words, they often don't eat well, they don't absorb well because their disease is small intestinal, and so they have resultant failure to thrive and then poor growth. Ulcerative colitis, on the other hand, involves the colon and the rectum only. If you see ileitis in these children, it's generally what we call backwash ileitis, where it's just basically backed up from the colon. This disease is superficial. You may see goblet cell depletion, which are the cells that, if you remember from physiology, they secrete the mucus that protects the intestinal wall. You don't usually see fistulas, strictures, or perianal changes. You often see diarrhea that may be bloody diarrhea with or without mucus. Extraintestinal manifestations are common in both pediatric and adult patients. We don't really know the cause of the extraintestinal manifestations. At times, they may have extraintestinal manifestations when they don't even have a flare of their disease. The most common extraintestinal manifestation is musculoskeletal, usually in the form of arthritis. Some patients don't actually have a diagnosis of arthritis, but they have a lot of joint complaints. Incidence of pediatric IBD. The incidence is rising. We don't know exactly why, but we think it has to do with environmental changes, urbanization, lifestyle, diet. About 25% of our patients are diagnosed before the age of 18. That means 75% of the patients with IBD are diagnosed in adulthood. The median age for pediatric IBD diagnosis is about 15. It's unusual to have IBD under the age of 10, but we have infants that have IBD. I have a handful of patients now who are under the age of 8. And so we'll talk a little bit more in a few minutes about what implications that has for the future of these children. Causes of IBD, it is multifactorial. We know that genetics play a role. About 30% of our patients have had a parent or other family member who has IBD. We know that there's an abnormal immune response that occurs. Environmental triggers play a part. We may have a whole family who has a GI bug running through the family. Everyone else got well, but that child did not. So we know infection plays a role. We know antibiotics play a role. We know that smoking plays a role. So there are more smokers that develop IBD than non-smokers, and we also know that smoking makes IBD worse. And then an alteration of the microbiota also is part of it, and that has received an awful lot of focus recently. So when we talk about pediatric IBD, it's important to note that pediatric IBD has unique characteristics. First of all, it is more severe in children than it is in the adult population. For example, in pediatric UC, on presentation, most of the children have pancolitis. In other words, their disease affects the entire intestine, the entire large intestine, as opposed to adults who are diagnosed with UC usually have either proctitis or just left-sided disease. Now, the next three bullet points here, I'm going to spend the next several slides discussing because they're very, very important in pediatric IBD. The first of which is delay in growth, puberty, and skeletal development. So this is a typical growth chart, which hopefully you can see okay. It's a patient who was diagnosed a male patient who was diagnosed between the age of 13 and 14 years of age. And what's key on this growth chart, particularly for primary care providers, as most of you are in the audience, is that this child had very little weight gain or growth in about a 3-year time. And he actually crossed 2 percentiles. And so what we really hope is that these children get diagnosed before 3 years go by. Oftentimes they have the growth problems before they have the gastrointestinal problems. And so because of that, people don't think there's anything wrong until they really look at that growth chart over a longer period of time and see, oh my gosh, this child is really not growing well. So we know that growth problems are more common in Crohn's disease. We know that it can affect final adult height. Velocities decreased. And it's important to think about what is the growth window for these children. In other words, most of these children are going to be diagnosed either pre-pubertally or during early puberty. And if we don't catch them and give them treatment to put their disease in remission, and decrease the inflammation, then we'll lose that growth window. Growth is also a good marker for disease activity, so once we put them on therapy and they start treatment and the growth starts to falter again, we know that maybe we don't have the correct treatment for those children. I have a patient right now who is 14 years of age. She is 4 feet 7 inches tall. She is as tall as she's ever going to be. She came to us at age 12. She had either started her period or she was just getting ready to start her period. And it's too late for her. I was never able to obtain her growth charts because the family, as many of our families are in North Carolina, is military, and they had moved around a lot, and the growth charts didn't follow her as they moved around. So I tried very hard to obtain them because I wanted to know for myself how long this had been going on. But this is a child whose mid-parental height should have put her at about 5'5", 5'6". She didn't have short parents, so she lost almost a foot of growth. She looks like a small child. Pubertal development is minimal, but she's done, or pretty close to being done growing. So it's something that we need to make sure we get figured out sooner than years down the road. So what affects the growth? The inflammation affects the growth, long-term use of corticosteroids, poor nutrition, and then nutritional losses. Depending upon where the disease is, it's going to make a difference in their nutrition, and small intestinal disease does make a difference. And then lastly, what is the interval from time of symptoms to time of diagnosis? So obviously a longer period from time of symptoms, and symptoms might not even mean GI symptoms, but symptoms meaning poor weight gain or poor growth, to time of diagnosis is absolutely crucial. So what affects growth also affects puberty. Like I said, this particular child does not look fully pubertal, but she is. More common again in Crohn's disease. The possibility of catch-up growth is there, again, if it's caught early enough. What affects growth and pubertal development also affects bone density. So we know that maximum bone is laid down in both males and females by the age of 20. And so if they're diagnosed in adolescence, that may have an effect on their maximum accumulation of bone. We know they don't take in calcium well. They know that they don't absorb calcium well. They may have low vitamin D. They may have decreased level of activity because they don't feel well. And if they've had long-term corticosteroid use on top of that, then they are going to be more prone to having low bone density. We usually do a bone density at diagnosis, and if it's abnormal, then we repeat it every year. But we really work hard to improve these children's bone density with weight-bearing exercises, making sure they have adequate calcium and vitamin D in terms of supplements if they're not getting enough through their diet. And then, of course, taking care of the disease, which also helps improve all of that. So diagnostic testing. Typical lab work is done with these children. Stool studies are also done. We want to make sure that there's no infectious cause of their symptoms, and the stool studies will help with that. We do fecal calprotectins. More recently, it's a newer test that we use, and that tells us about intestinal inflammation. What it doesn't tell you is that inflammation a result of infection, or is it the result of inflammatory bowel disease? Serologic studies, sometimes our patients come to us from the PCP having had serologic studies done. We don't usually do them. We usually do the full workup that I'm describing because the sensitivity of the serologic studies is not perfect. We almost always, and I say almost always because we're supposed to always do a TPMT pathway early on in these children. If we're going to place them on a thiopurine, we need to know how they're going to metabolize the drug before we start them on the medication. And I'll talk a little bit more about that when I talk about thiopurines. So diagnostic testing, radiographic evaluation, if we're worried about obstruction, we might just do plain films. Abdominal CT scan used to be what we would always do on these children, but we are trying to do this less and less unless we're in an urgent situation. And what we know now that we didn't know way back when was the lifetime exposure to radiation in these children is quite cumulative in terms of risk for cancer. So unless we're in an urgent situation, we try to do MRI on these children instead of CT scan. And the same goes for small bowel follow-through. When we were worried about small intestinal disease, we would frequently do small bowel follow-throughs just to make sure, and now we don't do those routinely in all cases because of the risk of radiation exposure. Everybody gets an upper endoscopy and colonoscopy. They get it in one shot, unlike adults who get it in two separate procedures, and we do that just so that they only have to have one anesthesia. We do sometimes use video capsule endoscopy, not as much as the adult population, but in certain circumstances we do. Obviously, the video capsule endoscopy does not do biopsies, and we need those biopsies to make the diagnosis, but we use it in certain situations where, for example, a patient is getting ready to undergo colectomy, and we're not 100% sure that that child has UC. And Susie will talk in just a few minutes about making a diagnosis, and then the subsequent surgery is done differently if you're doing a colectomy on a patient with known Crohn's disease who has pancolitis versus a patient who has ulcerative colitis. You want to be as sure as possible that you know going into it what the patient has. And in this situation, we have a lot of collaboration with our surgeons. So that's one example of when you do video capsule endoscopy. As I'm sure you know, when you do upper endoscopy and colonoscopy, there is an area of small intestine that you're just not reaching, and the VCE will also help with telling you what's going on in that area. So overall principles of treatment, there's a lot of information on this slide, and traditionally we really were looking for suppressing the inflammation and restoring normal growth and nutritional status. But really, very recently, the goal is to heal the mucosa, and treatment is looking at how do we best heal the mucosa. And that's really happened since the advent of biologics in the last few years. And so I'll be talking more about that as we talk about the different treatments in a few minutes. But the goal is to alter that mucosa, heal that mucosa, and keep it healed, and then subsequently alter the natural course of the disease. So treatment efficacy in pediatric IBD, we have much more data in the adult population than we do in the pediatric patient. A lot of our data has been extrapolated from adult studies. We know that efficacy is at least as good or maybe better in the pediatric patient in terms of inducing remission, but we have very small sample sizes in pediatrics, as you can well imagine, because parents don't want their children to be guinea pigs for some of these medications that we use, and concerns about their toxicity. Toxicity is going to be similar for pediatric patients as it is for adult patients, but we are very, very keyed into now what does that longer-term growth, what does that longer-term drug exposure mean for our patients? If you're talking about a patient that gets diagnosed at 10 versus a patient that gets diagnosed at 60, which is a common age for diagnosis in the adult patient, you have 50 more years of drug exposure in those patients. And we certainly think as our biggest concern in these patients is what does that mean in terms of cancer later in life. And then lastly, clinical trials need to consider what are pediatric specific outcomes? What are we concerned about in pediatrics? Certainly growth and bones are two important areas. So discussing risks of therapies. Pretty much of the care that I give my cohort of patients with IBD is independent. But whenever I decide that I'm going to escalate therapy, I always bring in the attending physician to discuss it with the family. It's a very, very difficult subject. for all of us. Parents are very, very worried about the medications that we use. And malignancy is the most dreaded complication for our families. They've read about these medications that we use online, particularly biologics. They're very afraid of biologics, and they often think that biologics are the worst of the medicines that we use. As we do more research over time, we're finding that that's probably not the case. But we haven't been using biologics for that long, so we don't know what the future is going to bring. Infliximab was improved. Our first biologic was approved for pediatric use in 2006. So when I started 17 years ago in pediatric GI, we didn't even have biologics. Adalimumab, our second biologic that was approved for pediatric use, was only approved last year. So those are the two main ones that we use. And sometimes parents will come and say, I've read online about the, terrible chances for malignancy in children. Well, you need to read between the lines when you're reading online, and we really try very hard to explain risks and benefits to the parents. We explain it in terms of absolute risk versus relative risk. And if you tell them the risk of your child getting a cancer from these medications is 3 times the average child's risk, that's very, very scary for patients. If you put it in a different perspective in terms of absolute risk, the average child's risk is 2 in 10,000. Your child's risk of getting malignancy is 6 in 10,000. It's 3 times the risk, but it's still very, very small. We talk about risk for infection, and that's where you all in primary care come in. We want these children to be fully immunized before they start immunosuppressive drugs. They need to be caught up on all their live vaccines. We try to put off immunosuppressive therapy until they've had all those live vaccines if they're not caught up. Sometimes we're not able to do that, but we do try very hard to do that. So if their primary care provider has kept them up to date and the family has done their part in that as well, then usually we can go ahead and start therapy right away. We also want to make sure they have annual flu shots because risk of infection can be very devastating in these patients. Risk of not treating is really, really important to discuss with families. They think these medicines are bad, they're going to hurt my child, but what is the risk of not treating? Well, on the one hand, you have a child who can't go to school, who can't be a normal child. So if you're starting to think about 50 years down the road and what that's going to mean for the child, if that child can't be a child and they're in the bed all day, then that's really important, right? And beyond that, what are the other risks? Risk of infection, risks of sepsis, risk of perforation, risk of abscess. So there's lots and lots of risk of not treating. So therapeutic options, there are lots of options, and I'm not going to go through every single option. I'm going to go through categories. Antibiotics are often used in conjunction with other medications in these children as a secondary medication. Sometimes they're used by themselves. An example is I have one patient who has only perianal disease, and she takes metronidazole, and that keeps it under control. So she's never needed anything stronger than that. The other medications may be used as monotherapy or dual therapy, and we'll talk a little bit about the need for dual therapy in a minute. So this is what we call our therapeutic pyramid for pediatric IBD. And really when you're thinking about the medical treatment approach, there are 2 approaches. There is what's called the step-up therapy and the top-down therapy. Traditionally, we always use step-up therapy. In other words, you start with the lower-level medicines that have the least risk of serious side effects, and you work your way up. Well, the problem with that is you waste valuable time on medicines that may or may not work for the child. So people consider, for example, the 5-ASA medications as low-risk medicines. They consider steroids as low-risk medicines, but as I'll talk about in a minute, that's not necessarily the case. what we've started to do more now is think about the individual patient and which patients need top-down approach. Many of them do, because children with pediatric IBD often present with very significant, extensive disease. So which patients should get the top-down approach? We don't have really good criteria for that. At this point in time, we look at what patients have extensive disease, which patients are very young, patients that have fistulizing or penetrating disease, patients that have perianal disease would all be candidates for a top-down approach, starting with either surgery in some cases or biologic agents. And that's, again, where we are working closely with the surgery team if, in fact, surgery is deemed the first approach to these patients. So steroids. We try very hard not to use steroids for a long period of time. Initially, we may use them to induce remission in our patients, but the goal should be to get patients off of steroids as quickly as possible. And we all know the side effects of steroids. In primary care, they're usually used for short-term periods, but in certain cases in IBD, they're used much longer. And short-term side effects are weight gain, acne, hirsutism, mood changes, worse than the usual adolescent. And then long-term problems are osteopenia, poor growth, and cataracts. So we don't want these children to be on them long-term. We know it has a negative impact on their growth and bone metabolism, and what adolescent wants to walk around Cushingoid? We also use budesonide for patients who have mild to moderate disease, which falls under the steroid category, but it's not as potent as the corticosteroids like prednisone. And we have two different medications that we use. One is pretty new that I've only used a few times, so I can't say how well it's worked for me. But one works for Crohn's patients, and it works in the terminal ileum, and then the other one works in the colon. That's the newer one. 5-ASAs. Again, they're at the bottom of the pyramid, so parents like those medications. But the problem is 5-ASAs are for mild to moderate disease. Few of our patients have mild disease. 5-ASAs also work better when there's colonic disease, whether it's Crohn's colitis or UC. And again, many of our patients have ileocolonic disease when they have Crohn's disease, and so a 5-ASA might be used in certain situations as dual therapy, but it's usually not going to be effective as monotherapy. They may be able to get away with rectal therapy. So if they have very localized proctitis, the local therapy can be very beneficial. The problem is kids don't like rectal therapy, and if they won't do it, then you got to come up with something else. So immunomodulators fall into two groups. We have thiopurines, and then we have methotrexate. Immunomodulators have, in terms of thiopurines, have traditionally been used commonly as a first-line maintenance medication for pediatric IBD. It isn't used for induction of remission because it takes a long time to take effect. So it takes about 6 to 8 weeks at least to get into the system. So you've got to have something else that you've done beforehand, either steroids or enteral nutrition prior to starting the patient on a thiopurine. The good news is it will allow you to get your patient, hopefully, if it works well for them, off of steroids. The main side effects are leukopenia and hepatotoxicity, but they occur infrequently. Usually the children do fairly well with this. The nice thing about the thiopurines is you can measure a level, a drug level, so you know whether your patient's adherent, and it also helps you to optimize the dose because different children metabolize the drug differently. We have been using immunomodulators in terms of thiopurines less recently, and that's because of the risk of hepatosplenic T-cell lymphoma, which is a deadly disease that has occurred in a small number of patients who have received a thiopurine or a thiopurine along with a biologic. For some reason, it occurs mainly in males, young males. We don't know why that is. It's a very, very small number. The number changes periodically. The last I heard was a total N of about 40. So it's a very, very small number worldwide when you think of all the patients that have been on immunosuppressive and biologic medications. But we have been paying closer attention to that, and in our pre-adolescent and adolescent males, we are often using methotrexate instead more recently. And that brings me to talk about methotrexate. We have not traditionally used methotrexate much, but I would say over the past 2 or 3 years even, the use of methotrexate has gone up significantly, particularly in the young male population. So we traditionally used it when they couldn't tolerate the thiopurines. Generally, discontinuation of the drug occurs due to nausea or elevated liver enzymes. In families that you may be worried about adherence, it's once-weekly dosing, so that may help adherence. It can be given either orally or subcutaneously. We usually start the children on subcutaneous injections, and then if they're doing well, we'll move them over to oral eventually. But again, when injections are hard for children, that may be very difficult. I have a 5-year-old right now who we thought he was doing well with his injections, and he's not. And it took so long to get him in remission that I'm a little hesitant to switch him over. But we're either going to have to switch him over or get him some pretty significant psychological therapy to help him get through these injections. Nausea is one of the big problems with methotrexate. And nausea can be managed by what we usually do is have the patients take their methotrexate right before bed, and then they sleep off the nausea. We give them a dose of Zofran with the methotrexate, and also daily folic acid helps with the nausea. Probably most important to remember about methotrexate is it's highly teratogenic, and so we are very, very careful about giving it to adolescent females. And when we do extensive counseling on contraception and ask them to be on 2 forms of birth control. So that brings me to biologic therapy. And again, we know biologic therapy works very well. We know it works well for putting our kids in remission. We know it works well for mucosal healing. We know usually if it's going to work, it works quickly. We have children who say they feel better within 48 hours of starting a biologic. We know there are toxicities. You can have infusion reactions, which will mean that they can't take the drug anymore, an allergic type reaction. We know it can cause malignancies, but again, most of the cases of the deadly lymphoma have been a biologic in conjunction with the thiopurine or the thiopurine alone. No cases of just the biologic alone. Infections can be a problem. We're very, very careful not to ever administer their biologic therapy when they have a known infection because the infection can get worse. And then with one of the biologic therapies, natalizumab, which we don't use very much at all in pediatrics, I've never used in any patient. You can have rare neurological disorders when they have been exposed to the JC virus beforehand. So in terms of pediatric patients, the natalizumab doesn't get used very much. Certolizumab doesn't get used very much because they're usually in the adult group by the time they start those. Our newest medication is called vedolizumab, and the jury's still out on that. We are starting to use it on some of our cases of refractory IBD. The downside of vedolizumab, it takes a long time to take effect, unlike adalimumab and infliximab. It takes months to get into the system. So you need a bridge to that. You need a bridge of more than steroids because it takes so long. What does this mean for our children? Well, it means they have to miss a day of school to get their infusion if they're on infliximab every 6 to 8 weeks. Parents have to miss work. If they're getting adalimumab or certolizumab, which we don't usually do, they get injections every 2 to 4 weeks, and that's usually done at home. Again, the child has to buy into that. And in the case of adolescents, they may choose not to buy into it. We give them a role in helping with the decision making. So lastly is enteral nutritional therapy, and this is gaining favor very, very rapidly. We know it's effective in inducing remission in patients with Crohn's disease, particularly Crohn's disease more than ulcerative colitis. So small intestinal disease, it works much better than colonic disease. What it can do in some cases is avoid steroids altogether. And that's really, really important because enteral therapy has very, very few side effects. It helps with growth. We're not really sure why it helps the disease. We know it decreases inflammation. We know it helps with nutritional repletion. We know that it also alters the gut microflora, which is important in treating the disease. Different centers do it for different lengths of time. The average is about 6 to 8 weeks. It can be done either orally, in other words, you just drink, one after another. Doesn't have to be elemental formula, or you can drop an NG tube and do it that way. Most centers early on for the induction use, 90-95% enteral therapy, and the child can eat a very, very small amount. So psychologically, it's tough. We don't have a lot of buy-in. CHOP has probably the best buy-in of any of the centers, and that's because one of the head gastroenterologists there has Crohn's disease himself, and so he does it himself, and he manages to get the kids to buy into it. So surgery in IBD, I'm not going to talk about much because Susie's going to be talking about that in just a few minutes, but it's important to think of it not as a last resort. It can often be used along with medical therapy for our patients with Crohn's disease. It's not curative for Crohn's disease because Crohn's disease is going to come back in another place if you take out part of that intestine. It is curative for ulcerative colitis. Most patients are going to require it at some point in their life. Just to give you an idea of how soon it happens in patients with ulcerative colitis, generally about 10 years out, 40% of our patients, pediatric patients with ulcerative colitis have had a colectomy. About 20% of adults who were diagnosed with UC as adults have colectomy. We also use it as cancer prophylaxis. What we know is 10 years after diagnosis with UC, we will have, let me see if I can get this right. After 10 years after diagnosis, for every decade, patients with UC have a 10 to 20% increase in cancer. So their chance of developing cancer colon cancer is much higher than in the patient with Crohn's disease. And so some people choose to do it not because their disease is so bad, but because of cancer prophylaxis. So IBD and quality of life. This is really, really important. Studies have looked at what do kids with IBD have to say about their quality of life. They worry about all kinds of things. They worry about their weight. They worry about their height. They worry about their appearance. They worry about feeling like they can't eat. If they're in school at lunchtime and they're going to have to rush to the bathroom afterwards with urgency, they're not going to eat. They'll skip lunch. They worry about their future. They worry about their future in terms of their disease. It's kind of a crappy disease. You can look at these children and they look normal in a lot of cases, but they aren't normal. And they have lots and lots of worries related to their disease. It's embarrassing to need bathroom breaks at school. I've had teachers who have told children when they come back in the room, "What were you doing in the bathroom for 10 minutes?" And they assume that the child is goofing off, but these children might need 10 minutes in the bathroom, and that should be okay. We make sure they have 504 plans in place that take care of their bathroom needs and a whole host of other things that they need, such as stop-the-clock testing. But again, we have people who are uneducated sometimes in the school system who don't understand it. They mix up IBD with IBS and they think the kids are goofing off when really they're in the bathroom trying to decide whether they feel well enough to come back to class. We try to have these children have psychological evaluations early on. Some parents and children absolutely refuse, but we like for that to happen, and we like to revisit that throughout the course of their disease. Depression and anxiety can be a big problem, so we want to assess for those. So psychosocial challenges, what does it mean? They have to cope with a lot. They have endoscopies and colonoscopies when we're worried, when we're escalating therapy. They often don't tell their peers what's going on. They often don't even tell their closest friends that they have IBD. It's not a topic that people like to talk about. People don't want to hear about bathroom habits. That's something that younger children are fine doing, but once you get into adolescence, it's not a cool thing to talk about. So it's really, really hard on these children. Depression and self-image. They have high anxiety. These children have about 5 times the risk of depression and anxiety that you find in an average adolescent patient. Studies have shown that probably about 20 to 25% of these patients have high anxiety and depression, and that's a very, very high number. It's something that we're looking into more and more and trying to do a better job of screening for that in our patients. Adherence. Adherence is tough for anyone who has a chronic illness. You put that with an adolescent, and it's very, very difficult. What are we hoping for? We're hoping that our patients will take their medications 100% of the time. Is that realistic? No, not even if they're an adult, let alone an adolescent. And so we're looking for at least 80%, but that's not great, right? What we're seeing is that the longer-term therapies have poorer adherence, very, very low in some cases. And we also see poorer adherence when the children feel well because they say, why do I need my medication? Because I feel good. So we try to make that easier for them. We know that if we prescribe prednisone and they don't want to have Cushingoid facies, they're not going to take the prednisone. So what can we do for them that will be better than prednisone? How can we help them understand the concept of maintenance therapy? Yes, you feel good, but you feel good right now because you're taking your medication. And then we try to minimize the number of pills and doses so that they don't have to take so many so that they're going to do a better job. And then lastly, what works for this child? If setting an alarm on their cell phone helps them to remember to take their medication, then we want whatever works for them. So, how do we help them manage their disease? First of all, they need to know about their disease. They need to know what type of disease they have. Do they have ulcerative colitis? Do they have Crohn's disease? And what does that mean? What medications are they on, and how do those medications help them feel better, and what's the importance of taking those medications? We try to have a really open, interactive, non-punitive relationship with our children and our families because it's really important to help them adhere to the treatment plan. We want to help them be positive. We know they're not always going to be positive, but we try really hard to maintain a positive attitude to help them as well, while getting them to increase their level of responsibility in disease self-management. And that brings me to the last of what I want to talk about, which is really healthcare transition. And eventually we've got to get these kids into the adult world. We've got to get them with adult providers, and it doesn't happen overnight. Ideally, this is a process. So transition is a continuum. Transfer is the actual transfer of care from the pediatric provider to the adult provider. What we want to do is we want to start at about age 12 to 14 and work up until 18 to 21. And during that time, we want to slowly educate them on what they need to know because they can't learn it all overnight. What we found in our work at UNC is that insurance and reproductive health are the two areas that they need more they need more education in, and we've tried to work on that with our patients. Oftentimes it's really hard to work on transition with these patients because they'll often come in with an acute issue, and that takes precedence over, okay, now let's work on getting you better able to manage your care. But we do work on this over a several-year time span and try to have them gone to the adult world by the time they're done with college at 22 or so. So goals of management, we're trying to manage their disease. We're trying to make sure that if they're at risk for nutritional growth failure, that we've intervened early to preserve and restore growth. We want to address their psychosocial issues and get them taking care of themselves. So what is the future? This is probably not that far in the future. They will get some sort of IBD panel that will give us an IBD subtype. It'll tell us how extensive or severe their disease will be, and then their treatment plan will be based on that. We've got lots of studies in the works. There's been studies on probiotics, and we know that can help, but it's not going to cure the disease. There have been studies on diet. We know that that can help, but it's not going to cure the disease. Fecal transplant has received a lot of press. That doesn't cure the disease. What it does do is it does help with recurrent C. difficile. So there's lots of research out there, and this is probably what we're focusing on the most. So lastly, I've just included some resources for you. CCFA is great, NASPGHAN is great, and Improved Care Now is an initiative, a QI initiative that is worldwide. We have over 70 centers in the U.S. and the U.K. Working on how to better improve the care of our children with IBD. And before I turn it over to Susie, and I thank Susie because she let me have a few extra minutes because I'm pretty passionate about making sure I talk about everything that I need to talk about. But before I turn it over to her to talk about the surgical management of these children, the title of the session is Collaborative Care, and what that meant was really collaborative care between the medical and surgical teams. But I think it's really important for you, as most of you out there are probably primary care providers, it's important to think about what is the collaboration that occurs between you and us. And when it works well, it works really well. When it doesn't work well, it works very badly. And situations where you can help us, I've had nurse practitioners diagnose children who have been followed by a pediatrician for months and hadn't figured out what was going on with the child, and the nurse practitioner has figured it out by maybe looking at the growth chart, maybe looking at the child's symptoms, but always, always, always keep that growth chart in mind. And if it's not IBD, it could be celiac disease. Secondly is making sure, as best as possible, that these children are up to date on all their immunizations, not just the live, but all immunizations. And then lastly, they're going to be coming to you for their primary care needs. They try to come to us for their primary care needs because we see them so much. They think that we'll just handle everything that could possibly happen with them. And that's not true. We want them to have primary care providers, and we want to work with the primary care providers. So we want the primary care providers to handle all the primary care needs, but when they're seeing them on a Friday afternoon for a GI issue, we want to have collaboration on what's going to happen with these patients. We don't want these children to be placed on steroids without us knowing about it. It's very, very important. So probably that would be my biggest take-home point is we want to work with you in caring for these children as best we can. Thank you very much.
Good morning, everyone. I'm Susie. I'm a nurse practitioner at Ann and Robert H. Lurie Children's Hospital of Chicago, and today I will be talking with you about surgical interventions for patients with IBD. I thought this was a really great opportunity for collaboration between a GI colleague because truly, as a surgery group, we don't do anything without them. They're the ones who call us and get us involved when they think it's appropriate and when they think it's the best thing for their patients. I don't have any disclosures. And starting off this morning, can you guys just show me a show of hands who has seen this picture or a similar one? It's actually not as many as I thought. So this is Bethany Townsend, and she has Crohn's disease. She was diagnosed when she was 3 years old, and she had a stoma placed in 2010 because she had perforation of her intestines. She has kind of gone viral with this picture, and so I thought it was important to bring it up that these things are kind of out there in the media now. People are having these conversations, so you probably will see this more in a primary care type of setting. She even has a hashtag that goes along with this that is hashtag get your belly out. So if you want to see some more stoma selfies, you can look that up. So before we get started talking about any kind of surgery, I think it's important to talk about anatomy and physiology. So I will try and use this pointer over here if you guys can see. The first thing I want to talk about is the small intestine. Can you see over there? Or can I do it behind me? Maybe I can still talk here. I'll go over here. Sorry. So the small intestine is made up of 3 different parts. It's kind of all stuck in here behind the colon. So what we're looking at here is the first part, which is the duodenum. And to keep in mind what that does is it actually breaks down fats, carbohydrates, and proteins. And if you kind of think about where the pancreas is in relation to where the duodenum is, it makes sense because you're going to have some stomach enzymes coming into the duodenum here, and also the pancreas is going to dump some digestive juices, so it's still helping with processing nutrients. Next, we have the jejunum, and basically what that is going to do is absorb nutrients, everything that's been processed before. And then the last part of the small intestine is the ileum. This is the most important part of the small intestine for all absorptive and nutritional purposes. So when you're losing a part of your ileum, that's going to have more of an effect on your patient than even losing their stomach. So keep that in mind if they have some kind of intestinal procedure to the ileum. And then, of course, important always is the colon. So that is probably all of us can recognize that. And then right here is the ileocecal valve. And whenever we're doing a surgery, just as an aside, we try and retain the ileocecal valve if we can because it controls the liquidy stool from the small intestine going into the colon. Just helps them have a little bit more control. And so this is just kind of what I said for your handouts. So indications for surgical intervention in the management of kids with IBD. There's a lot of information on this slide, but I think it's good to have in your handouts if you ever want to refer back to when it might be appropriate to give us a call. A lot of times it's medically refractory disease, and what that means is it's either not controlled, not responding, or another time when we're called is sometimes the side effects are just too much, and that's particularly with ulcerative colitis. Crohn's kids usually are on their medications lifetime. So in Crohn's, the disease process, things that we would get called about is if there was intestinal perforation, if they had developed an intestinal fistula, and I'll talk about that a little bit later, excessive or uncontrolled bleeding, meaning they're getting transfusions and they're not able to control that with just medications, intestinal scarring, which basically means that part of the intestine has scarred, it's unable to absorb nutrients, and therefore it's not functioning. It's also placing the patient at higher risk for a perforation. Or a stricture with obstruction. A stricture is a narrowing, and that can happen in actually both types of IBD. If the patient is septic, we often get a call for at that point to intervene, or if they're having growth failure and looking for an alternative therapy. Ulcerative colitis, we usually get called if there's a perforated colon, we're taking you to the OR the same day. That's a medical emergency. For excessive or uncontrolled bleeding, that's usually from the ulcerations. If they're having growth delays and just want to stop taking their medications. If they have toxic megacolon, that's where the colon is large, floppy, full of bacteria and at risk for making the patient septic. Or if they have the concerns of a risk of colon cancer like Maureen had mentioned. So surgical preparation, this is just kind of a general slide, what we do before we take a patient to surgery in general. So the first thing we're going to do as a surgical team is we're going to look through their chart and their history and talk with our GI colleagues. We're going to see what kind of imaging they've had done recently, where the infected bowel is or the affected bowel is. Any medications that they're on, this is really important preoperatively because if we can get them off of steroids, that's going to be the best bet for us for healing. If they can't get off of their steroids, they're going to need extra when they're in the OR because their cortisol response is going to be suppressed. And then if we've had any other previous surgeries, a lot of times we've been involved with these kids kind of over the course of a period of time if they're having a flare-up, so we like to know where we've been before. After we've looked at all that, we like to sit down with the family and say, this is what we're thinking we're going to do. We talked with your GI team and they agree. This is what we're trying to do right now short term, and if applicable, we'll talk about long-term goals as well. Maureen talked about nutrition, and it was at the top of her pyramid, which I thought was great because that's really important for us for healing after you've had your surgical procedure. So if this is a stable patient, what we'd like to do is give them a little bit of time if they're not in good nutritional health. And she talked about maybe doing some supplements. We're also in favor of that as well. If they're not able to do it orally, we would do an enteral supplement, maybe through an NG tube. Or if it's really a problem and they're not able to eat or drink anything like that, we would consider doing some short-term IV nutrition. After we've looked at their nutritional status, before the surgery, we will have the stoma nurse come and see them, and this is more for patient preference, really. It gives them a little bit of control in this situation where they probably don't have a lot of options and choices. The stoma nurse is going to help decide where the best place for their stoma would be in relation to what they normally wear, and also just kind of how they feel about their bodies. They can take that into account as well, because the surgeons will have a little flexibility of where that will be placed if that's what's going to happen. And then prior to surgery, what we usually do at our institution is a bowel prep. That's what we call it. If anyone's had a colonoscopy, that's basically what we're doing, except for we monitor the kids in the hospital overnight. So they basically get a high volume of the Go Lightly medication at a short period of time to kind of flush out all of the intestines. If they're not able to do that, we'll put a tube in their nose. And I just have to mention that right now, it's not something that's a standard procedure with all surgical teams, so your patients may or may not be getting that. I think in the next 5 years, there will be a surgical consensus, but right now it's kind of institution specific. So with Crohn's disease, there's several reasons why we would do an operation. So if they developed an abscess, and this could be intra-abdominal or a perianal abscess, and some of these things will actually happen together, so we would be doing a combination of procedures. If they developed a fistula, and the best way I can describe a fistula is it's a connection between two tissues. So if anyone has an ear piercing, that's essentially a fistula. It's going between two different things as kind of a tunnel, and things can move in between it like an earring. An obstruction is just a blockage of your intestine. It can be from different things. The disease, if we've done surgery before, the scar tissue might cause an obstruction. Or stricture and scarring, and that's just from the disease process. And then perforation, obviously, we would be hopefully called right away. So this is just a picture of a fistula. If you guys can see, I think the picture is the easiest way to show you if you can see my pointer. This is just the tract that forms from the anal canal out to the skin. And so this would be like a perianal Crohn's disease example. In some of our patients, what you'll see is at the beginning of the fistula, there would be maybe an abscess or infection that has kind of opened. We actually hope it drains out and is not draining into the intestinal cavity or into the intestines and making the patient septic. So we're actually sometimes happy to see a fistula because we can kind of deal with that a little bit better. Surgical procedures would include doing an incision and drainage of the abscess if it was easy to get to. We could do an abscess drainage with a Seton placement, and I have a pretty gross image coming up next that will show you what a Seton looks like in an actual patient. So I apologize for that, but I wouldn't be a very good surgery nurse practitioner if I didn't show you at least one gross picture this morning. A fistulotomy, which if you looked at the previous picture, we would either let that fistula heal with the Seton placement that you'll see, or we would go in and actually remove the section that had created the fistula. If we're doing more invasive surgeries, that could get up to doing a bowel resection to remove an affected piece of bowel that just wasn't responding. A lysis of adhesions. So adhesions are just scar tissue that forms across the intestinal cavity. It can sometimes kink off your intestines. If you think of a garden hose, that would be the kink. Those are usually fairly easy to treat, but again, every time we do surgery, they're going to form those adhesions, so we just hope that they don't form across the intestines. And then a strictureplasty. So a lot of these patients do have strictures or narrowing of the intestines. And so we can do a couple things. We can do a bowel resection and take out that part if there's really no good way to go in and open it back up. Or we can do a strictureplasty, which is cutting along the narrowed part and then putting the ends together. It's kind of hard to describe. And then long-term, if you really have problems and need to divert, we would do an ileostomy. Sorry for the gross picture. So this is pretty bad perianal Crohn's disease. This is actually the patient that I'll talk about in my case study. This is one of his first surgeries that we did. So you can see that he has the ulceration, he has the abscess that is draining through. So he had a combination IND as well as Seton placement. And the Seton is basically just a loop of some sort of either rubber or medical grade plastic that is inserted in and tied together to keep the tract open. And it basically just lets everything drain out. And what we're hoping is that it heals itself, because if we don't have to do surgery, we really wouldn't like to. And in this area, it's important to notice that we're not anywhere near the sphincter complex doing the actual procedure, because we really don't want to operate on that because they can have problems with continence later. So this is a good image of a strictureplasty. If you can see, they make an incision along the part where it's really narrowed, and then instead of just sewing it back up, they put the long ends together, and that kind of opens up the intestine a little bit more. This is really good for Crohn's because it means you're not losing a part of your intestine. And this is a picture of an ileostomy. Have you guys all seen ileostomies before of some sort? If not, this is a pretty fresh post-op ileostomy. And I picked this picture from one of our patients because of the cord that you see there. That's called a bridge. This is a loop ileostomy, and I have a picture of loop versus end in just a second. I'll show you. So basically, they're taking the intestines, pulling it up to the skin, cutting an opening, and attaching it there. And this bridge is there to hold it in place so that there's no risk of it falling back into the abdominal cavity. And so this is just more for your reference to see the difference between an end ileostomy, where there's just a piece of intestine brought straight up, or a loop ileostomy, where there's two pieces there. So postoperative considerations for the patient with Crohn's disease. Again, nutrition, that's usually our number one. If you're not well nourished, you're not going to heal from your surgery. Routine postoperative nursing care. We have really great nurses, and with a little bit of training, I think everyone can. Important things for postoperative patients in general: get them up, get them moving. To do that, they have to have good pain control. Anytime we're doing an intestinal surgery, we have the patients they experience what's called an ileus, which basically means your intestines kind of go to sleep for a period of time until they're able to recoordinate and move with gravity again. So until that's happening, we usually have an NG in to decompress, and the nurses have to troubleshoot that as well. Multidisciplinary care. We get our GI colleagues involved pretty much the day after surgery. A lot of them come and see their patients postoperatively just to kind of reestablish care and make sure they're doing okay and see if they have any questions long term. We also discuss all of our surgical findings in detail with them so they know kind of what we found. And then resumption of any medical therapies and medications when it's appropriate. We usually like to wait 2 weeks for that, if it's okay. So surgical complications. There's always a risk if you're having some kind of surgery. An anastomotic leak. An anastomosis is when you're taking two pieces and putting them together, so there's a suture line. That can leak inside the body. And so what that would mean is that you would have some digestive juices and poop, really, going into your abdominal cavity, and they can get pretty sick from that. That would be a reoperation. Abscess formation. This could be from the disease process or from the surgery. It's about a 5% risk of an abscess from doing a surgery. Adhesions, that's the scar tissue that will form just from us being in the abdomen. A stricture, that could be from us doing the surgery or from the disease process. The fistula is more from the disease process, and then recurrence with Crohn's disease is expected. If we get involved once, we're thinking we'll probably be involved again. And so we can transition to ulcerative colitis. I broke them up separately because they are pretty different surgically. There are some things that go for both, but what I'll talk about is our kind of our main reason why we're called in for ulcerative colitis in kids right now is one of these options that I'll talk about the most, so I wanted them to be separate for you guys. So reasons that we would operate, if it's emergent, that would be like severe bleeding where they're getting transfused a lot, or toxic megacolon where they're at risk of perforation. We would be called pretty emergently for that, and we wouldn't have time to optimize nutritional status or adjust medications in that case. But for planned surgeries, we do have a lot of patients who come to us choosing to get their colons taken out. So these are normally stable patients. They have either not responded to medical therapy, they're tired of taking these medications, they're worried about cancer, or they just don't want to have a stoma if they've already had one. So there's 4 different things that are commonly done, and not all of them are done in children, but I wanted you to at least hear about all of them. So a conventional proctocolectomy is basically where we're taking out the rectum, procto, and the colon, colectomy, and we're basically giving them a stoma, an ileostomy, for the rest of their lives. That is the first option. A lot of people don't love that since we have alternatives now. The next option would be a colectomy, taking out your colon and making an ileorectal, so taking that piece of small intestine and attaching it to the rectum. And that could be preferable over an ileostomy, except for you don't have a place where your stool is going to be able to be stored. So you kind of have a lot of urgency, a lot of leakage, a lot of embarrassing moments. So we don't do that very much in kids at all. A proctocolectomy with a Cook pouch. This sounds really good on paper. So this is where we're taking out your rectum and your colon. We're making a pouch of small intestine, and we're securing it in your abdomen. We're then making a little valve where you can put a tube in, intubate that, and drain the poop out at different intervals of the day when it's kind of convenient for you. That sounds great because you're not doing a major pelvic surgery. However, that valve that we're creating really has a high rate of failure. It stops working. The tubes going in and out all the time really damage the tissue, and so we do reoperate on those a lot. I actually have not seen us do one of those in the 6 years that I have been working in this position. And then the one that we kind of do the most, and is potentially my favorite, if that's a thing, is the proctocolectomy with ileal pouch anal anastomosis. That's a lot. We call it the J pouch for short, and you'll see why, because it's shaped like a J. So that's a lot easier to say. The structure and function, it's a little pouch that's made of the ileum, and basically we're doing that so that it can mimic the function of the colon that you now don't have. It's just going to store stool and also help absorb some of the water that you're going to get from the small intestine. There are 3 different ways that we can do this surgery, and it depends on how healthy you are, which one we choose. So I'm going to start at the bottom. So the one-stage procedure is basically where we take out your colon, we make your pouch, and we attach it to your anus all at once. And so then when you have your bowel function return, you're kind of pooping through your fresh incisions and your fresh new pouch that we would like to keep clean. So we have probably only done this once since I've been there, and it was someone incredibly stable, off medical therapies for a very long time, and they did well. The 2-stage procedure, I'd say, is more what we do for our typical stable ulcerative colitis patients. So the first step is taking out the colon, making the J pouch, and then we give them a diverting ileostomy, which is where the poop comes out so that the pouch can heal in the pelvis. And then after that, about 6 weeks later, we'll go back, we'll close the stoma, let them start learning how to poop again, and so it's only 2 procedures. For our really, really sick patients that we get consulted urgently in the hospital, we do a 3-stage. The first stage is taking out the colon and giving them a stoma, and basically we're doing that to get their colon out. So if you remove a colon for UC, that's kind of a cure. We can get them off of steroids, get them off of medications, and give them a better chance to heal after they've had the procedure done. The second surgery is kind of the biggest one. That's where we make the J pouch, and they actually do a different stoma. So the one that they had before becomes your J pouch, and then they create a new stoma, put your pouch in place, and then you're still diverting stool at that point. And then 6 weeks after that, if you're doing okay, we've done a study of your pouch, we'll take your stoma down and you'll be in continuity again. So this is just a little picture of what that looks like. And if you can see, there's a whole bunch of suture lines on there, which we'll talk about in a second. I wanted to put these pictures in just so you can see more what we're talking about. I think everybody understands what a colectomy is. That's just a picture of us taking out the colon and or the rectum. And then an ileostomy, so that would be the first step. And then this one's a little bit harder to see up here, but it's good on your handout. So this just shows us how we're making the J pouch. We're flipping up that loop of ileum. We're going to secure it together and then open the 2 together so it really creates a pouch. Once the pouch is made, we're bringing it down into your pelvis and we're attaching it to your anus. And then the last picture just shows what it looks like after the whole thing is done. So you have the pouch, the colon is gone, and then you have the stoma. And then after your pouch is healed, we usually do a rectal exam under anesthesia, or we'll do a scope before the patient goes home from the hospital after their pouch is created to make sure that there's no infection, all the suture lines look healthy, the pouch is viable, and if not, you would be getting a reoperation probably before you go home to make sure your pouch is okay. Just something to add, once you get a pouch, that's kind of your one chance to have one. This isn't something that we can then use different ileum later. So you kind of get one good shot, which is why we have to make sure they're nutritionally in the best condition they can be and off all medications. So I like this picture just because it's a before and after, and I think it's not totally obvious what we've done, but if you look, obviously the colon is missing, that's gone, and then we have a pouch in place and there's no more stoma. So it just kind of gives you an idea. And also, the volume, the amount of the small intestine in the second picture is less because we've used some for the pouch. There's a lot of really specific information that I didn't include about how long the pouch should be, how much tension there can be when you're putting the pouch into the pelvis, things like that. It doesn't really matter from once they're discharged perspective, but if you guys have more questions on that, I'd be happy to answer them. So post-operative considerations for a patient with a J pouch, again at the top of my list is nutrition. And so we do a couple of different things. We like our patients to do a food journal and keep track of what they're eating when they have their stoma. This obviously isn't something if we do it all at one surgery, but most of them have a stoma at some point. The stoma becomes their pouch. So if you're eating pizza and you have a ton of gas come out and it's embarrassing for you or difficult to manage, you know that your J-pouch is going to give you a ton of gas when you have it in place. Other things that tend to cause problems are things like red sauce, like pasta sauce, seems to be a real problem for people with a J-pouch, causes some dumping. Sugar can be really difficult, so you have to kind of encourage them. It's hard. The little kids, the parents will do this for them, and so that's great. The teenagers don't want to be bothered with keeping track of their bodies a lot of times, and so we just have to make sure that they're really learning how their body is going to be different after this. And things that we don't want them to really eat right away. We don't want them doing high fiber foods. We don't want a lot of raw vegetables, a lot of seeds, a lot of nuts, things like that. Spicy foods can be really irritating to the fresh pouch, and also our teenage patients shouldn't be doing that anyway, but alcohol, because we know that some of them will be. And caffeine. This is a big thing if you're taking a history and somebody's doing 10 Monster Energy drinks a day, that's going to have to probably stop before that they've had this done. And also, any of these extra foods can cause anal irritation, so we limit that because they'll have problems with that anyway. Routine postoperative nursing care. So we talked about this a little bit with the Crohn's procedures. This is a little bit more involved with a J-pouch patient. A lot of times they're not allowed to get out of bed for the first 48 hours, but that will depend on the surgeon and how they felt like things went in the OR. If it was a really difficult pouch to create, some are very easy and they go very well, but if your intestines are not as healthy, it's going to take some more time. So they will be on bed rest. So the nurses have to do a really good job of repositioning, doing pulmonary toilet so they don't get pneumonia on top of this. Antidiarrheals. So this is something that we often start in our patients when they have their stomas. And what we normally like to start with, if they need it before they go home, is an Imodium. And then we typically watch them for about 24 hours and make sure that we have the right dose. Imodium is something that you can actually take a whole lot of before having any problems. And if you remember that using the ileostomy is going to have a lot of extra liquid lost, so the patients need to drink more, the Imodium will also help with that, so they're not losing as much liquid. If Imodium is not working, sometimes what we will go to is Lomotil, and that's a prescriptive. It also has atropine as part of how it functions to kind of slow things down and dry things up. So just keep that in mind that atropine can be a little bit addictive. It's not something I've seen our patients have a problem with, but it's just something to keep in mind if you're choosing to use that. Skincare. So basically, if you've ever had a patient before that had a stoma closed and then they're going to start having poop on their skin again, that's going to really be irritating. If you can, it's like potty training, essentially. They're going to have poop that's on their skin, and that skin has actually been protected by a stoma for quite a while. So they're going to actually need butt paste and diaper cream, and the teenagers really love it when we talk to them about that. But the alternative is that you get ulcerations and you get skin breakdown, and it's terrible and uncomfortable, and you've just had a major surgery. So we would really like to keep your skin in good shape as much as possible. Something over the counter is fine for that. They just need to be really diligent. Timed eliminations. So this is with poop. You're basically going to have to relearn how to poop and kind of potty train yourself, depending on the age of the patient. Little kids, the parents will do this for them and help to remind them when to go to the bathroom. But during the day, we like them to get up every 2 hours, try and go to the bathroom. They might not feel it. They might just have a little mucus, but we want to know all that information so we can better help them when they transition home. Overnight, for the first few days, they have to get up every 4 hours and try and eliminate. It's really important that they're not, even though they can hold stool, we don't want them to hold stool for too long. This pouch is not designed to work like your colon where you can maybe go every day. This is going to be still 6 to 8 times a day, but it's going to be a lot better than having a stoma bag if you really don't like your stoma bag. So any patient that's kind of gotten in trouble, and it's usually teenagers who are in school and don't want to go to the bathroom to empty their pouch, we encourage them to keep emptying it if they've come in with any infection. Kegel exercises. So this isn't the typical Kegel that probably everyone has heard of before. This would be like an anal Kegel, tightening the muscles, relearning the sensation, and we've stretched everything out, if you think of it that way, when we've done this surgery. So it's important to kind of get everything back under your control. Multidisciplinary care. So again, we're going to get our GI colleagues back involved immediately. They're going to take it pretty much from here, and we're going to do surgical management, but they're going to be following these patients for a lifetime with us involved as needed. And if they're on a steroid taper, if it's a patient that hasn't been able to come off of their steroids, usually our GI colleagues like to manage that. Returning to school, I included this for your handout so that if you guys have patients like this, you can use it, feel free. This just gives our patients kind of liberty to go to the bathroom privately, use of a private restroom as often as they want, as long as they want. They can keep supplies at school. They can go home if there's ever an emergency, no questions asked. And we always include at the bottom, please call us if you have any questions or concerns, because we really want our patients to be able to empty their pouches so they don't have failure. Potential complications of a patient with a J pouch. The first 4 are really just post-operative surgical in general, so I'm going to focus on the ones on the bottom. So pouch-related dysplastic and neoplastic transformation. So this would be like a cancerous concern. When we make the pouch, we do take out all of the rectum except for 2 centimeters. So that does place the patient at a very small risk of having some kind of cancer develop in the 2 centimeters that are left in the rectum, and that's for continence. So those patients have to have a digital rectal exam once a year. Pouchitis, so that's inflammation of the pouch. That's probably what we see most commonly. I'd say about 15 to 20% of our patients get this. It's usually from holding stool too long, so we'll just kind of re-educate about needing to empty their pouches. Infertility, so this is something that I don't hear that much about other than when we're talking about it pre-operatively. So if you're doing surgery in the pelvis, particularly in a female patient, you're going to have some risk of inflammation, maybe some infection in the pelvis, which can lead to essentially fallopian tube scarring or dysfunction. So there is a risk about 20% of female patients will have some sort of infertility problems over their lifetime. It's just something that they need to know about because it really does affect their decision. Some people choose to have a stoma over have this procedure for that reason. And then sexual dysfunction is more of a problem with teenage boys, and we do ask this question for all of our men that come into the office. Are you having problems with erections? Are you getting them unwantedly? Are you not able to have one if you would want one? It's important for their overall health, and so we have those conversations with them. So that brings me up to the case studies. I think it's just easier to understand what we're doing kind of if you hear the whole thing put together. So this was an 18-year-old female, and you can see what you think. I don't think I gave away what she had, so maybe you guys can guess. She's an 18-year-old female who was originally treated with Remicade. She had bloody stools on Remicade requiring transfusions. She was in the hospital for about 3 months at a time. She had growth delays, even though she was still fairly tall, loss of weight, and fatigue. So our GI colleagues did a scope, and they found some diffuse ulcerations and pus throughout the colon. And she'd been here for long enough that the family was just kind of done with their treatment course and all of her complications, and so they were seeking out a cure. So does anyone have an idea what we're treating here? Ulcerative colitis, because you can't cure Crohn's. So the surgical course, she was sick when we got her, so she had the 3-stage procedure. She had the laparoscopic total abdominal colectomy, so we took out her whole colon using the camera minimally invasively, and then she had the diverting ileostomy. She actually had a lot of problems with her stoma, but I'll talk about that in a second. Her second stage, 3 months later, after she was off most of her medications, she was still on some steroids. She had a laparoscopic completion proctectomy with ilioanal J pouch, so she had the J pouch done. And she had a diverting ileostomy at that point as well, because we do 2 if we're doing the 3-stage procedure. She came in a couple times with symptoms of a bowel obstruction, vomiting, not stooling, serious abdominal pain. And eventually her stoma was actually closed early because she was found to have, during one of our exploratory surgeries, she had 2, that she had sort of almost volvulized her intestines around her stoma. For some reason, that's a higher risk, it seems to be, in these patients with intestines because we've pulled the intestines to a different location. So it's a little bit higher risk stoma there. And then after we closed her stoma, she really didn't have any problems. She comes into the clinic about every 6 months. She's doing great. She's gaining weight. And she hasn't had any additional bleeding. And then this is the case study of the child that I showed the picture, the gross picture earlier. So he's a 13-year-old male. He's been on a ton of medical therapies that have escalated, and he's really not responding. He's had weight loss. He's pooping a lot, started to get bloody. He's had fevers, growth delays, and joint pain, and most importantly, perianal pain. I think you all saw that picture, and that doesn't look like it feels very nice. So his workup, he had an MRE, basically showed that he's got long segment involvement. And then he had a CT scan, and that was more for our operative planning. So he had colonic wall thickening, and he had an abscess that we saw there, and obviously you guys could see that. So his surgical course, he had so many problems with getting his nutritional status to a good place. We tried oral supplements. We tried an NG because he was his 13-year-old age. He didn't want to go to school with an NG, which is understandable. So he actually ended up getting a G-tube before we did a lot of his therapies. So that was his first procedure that we did for him. Shortly after that, when he was in a little bit better state, we did incision and drainage of the perianal abscess that you saw, and we placed a Seton. He actually had 2 separate ones that were done at that time. That was actually a picture while he was kind of healing. And the Setons stayed in place for him, luckily, for a long time. Placing the Setons, I should just add, is a procedure under sedation, but if we're not really doing anything surgically other than draining the abscess, we're kind of just inserting that to keep the tract open. So after that, he also got a central line during his procedure so that we could give him TPN, since he didn't want to have the NG, and he wasn't a huge fan of his G-tube feedings after that, of course, either. And then eventually he had to have a stoma created because he kept having these perianal abscesses that were forming. They weren't really responding to conservative treatment, and we were trying to avoid doing the fistulotomy because he had had them before. So he had a stoma, and actually since then he has been doing really well also. He has been gaining weight. He hasn't been needing to escalate his medical therapies, and actually he's been able to be weaned off some of them with the GI team. So this is just to kind of summarize the difference between the two. For Crohn's disease, again, to cut is not to cure. We want to be involved only if you really need us. We don't want to go in there because what we take out is going to likely lead to something else happening in a different place. And for ulcerative colitis, like I mentioned with the J-pouch procedure, taking out the colon and giving them the pouch, surgery can be a cure for those patients. And so people who don't want to deal with a stoma or just aren't as healthy from their treatment, that's a really good option that they should at least consider. It's not for everybody, but it's definitely something to consider. Okay, I think that brings us to the end of our content. So if anyone has questions, Maureen will join me.